I will be building on the work that I'm doing for the Minds Network, but also this is my thesis. I finished it about 5 years ago. In the Netherlands, what we do is we print books when we defend our PhD thesis. And I printed so many that I still have spare books. So I brought 2, which was all I could bring in my carry-on luggage. So hopefully 2 people among you will be interested enough to maybe bring one back to your home institution. This was about these new genomic technologies that we heard about this morning, about these microarrays. But I was mostly focused on the use of these technologies in healthy persons when I was doing this work. So I will draw a little bit on that too. So for the Minds Network is actually quite ambitious. I don't know if you've a good idea about what it is doing. I don't. I feel that I don't yet even know what it will be doing, but the research program is broad, trying to bring together expertise in the area of neurodevelopmental disorders in combination with rare copy number variants, maybe also develop standard operating procedures for when to do tests and what sort of tests, how to register clinical data, how to share clinical data, how to make arrangements with patients so that they agree to the future research use of clinical data and sharing that across countries, all the way until maybe using samples to develop patient-derived pluripotent stem cells and to do drug screening and maybe develop even therapies for neurodevelopmental disorders when caused by copy number variants. But this is a large research program, and it gives rise to a lot of ethical issues that are not new necessarily, but because this research program combines so many of these aspects, it does give rise to a sort of a new set of issues. But we know these issues from research involving children and adolescents already. We know these issues from genetic and genomic research, or maybe sensitive usage of patient samples and patient data. And we know these issues from maybe the blurring of the boundaries between clinical care and research, because we're repurposing clinical data, not just to benefit this patient by giving him or her a diagnosis or a prognosis, but we're also using those data for research purposes that have a very different aim. So these issues do exist already, but because we are combining all these efforts into one research program, this gives rise to sort of a new question. So for work package 1, we are trying to comply with task number 3, that is to map the ethical issues. And I'm doing this with a bioethicist from Latvia. We could think of a whole list of issues that are of interest, and I'm not going to discuss all of these things. I just picked out 3, but as you can see, there are a lot of different types of issues that we could be talking about. We presented this also at a previous meeting of the Minds Network, and this is something that we also corroborated with the people who were present. Yes, all of these issues do arise. And also, in addition, we are now working on a review of these, of the literature to find if this list is more or less complete. I will just briefly skip through the details of this, just because I think it's a little bit funny, some aspects of it. Namely, so we devised a search term with an information specialist who is actually quite a superstar in developing search strategies for systematic reviews. This is what it looked like. We found a lot of articles that were somehow discussing these issues, and we included about 150 articles in our review. We're now currently working on getting the results ready, but as you can see, also in our results section, we will have to regroup this into sort of meaningful themes, because this is already too much. We find a lot of issues that we could be talking about this afternoon, but we cannot. So I made a choice, and I sort of prioritized 3 things that are interesting to me, but the idea is also that we talk about things that you find interesting, because maybe you have different priorities, maybe you're interested in different topics on that list. So we'll try to sort of do both things. So in terms of research ethics issues, I think what we're doing now is actually quite interesting. And I'm sort of drawing on the work that we did for the literature review. So I'm sort of quoting articles that are included in our search to sort of illustrate these points. In terms of research ethics, basically the problem is that when we do research, we want to develop knowledge. But we have to use human subjects, human bodies, in order to do so, more or less. And when research is undertaken in children who do not have the capacity to consent, research that is not directly going to benefit this child, is it then justified? So there's a lot of questions arising in relation to, is it okay to involve children in research when they do not necessarily stand to benefit? In this type of research too, we're not offering them a clinical trial or anything, we're not offering them therapies, we're just asking them to donate their data and their samples for research purposes, so they might not benefit. So can we include children? And then this is also a balancing act. So we find it very important to conduct this kind of research, to generate these results, and to advance medical care for these kids. But the risks and the burdens come to rest on their shoulders. And these should probably be minimized. And this is also, of course, European regulations demanding that the risk should be minimal posed to children. But you can also sort of work the other way around. Oh wait, this is also something that we've found. And I think that this is also especially of relevance to the type of research that we're talking about today, because this is children with NDD with rare copy number variants. And so they're interesting from a research perspective. These are interesting children. And so choosing to recruit only families as research participants, and particularly targeting siblings at birth, for instance, has the potential to place unfair burdens on families with a child with autism, for instance, because these children may be sort of in high demand for researchers. So maybe you have this accumulation of research participation for these children, and therewith also an accumulation of the burdens associated with that participation. But this is all sort of from more or less a negative point of view. I will talk about the benefits a little bit later on. And I found this. This is a framework which was developed by a team in North America. A framework that says if you're going to do genetics research in children, you're going to have to take these things into consideration. And I have found sort of examples or illustrations of all these 4 points. For instance, this is something from a research project, Imagine Idea. We saw it on a Minds meeting earlier. I really liked it. According to very many national regulations, researchers should involve as much as possible the children when they are research project subjects in a project. Mostly, of course, consent is given by parents, especially when children are under 12. But the idea is that you do involve children as much as possible. And this is a book that was developed just to sort of explain to children what the research was about that they were participating in. And I thought it was a nice example of sort of showing respect for these kids and helping them to understand what was happening to them. Also, there are questions around when children grow and grow older, should they at some point be approached to actively ask for their consent at that point? or maybe when they reach the age of maturity, maybe they want to decide themselves whether or not to continue with the research. These are also important questions. There is this trend in terms of consent, I guess, also with the GDPR, towards ever more explicit and more specific consent. This is something that is a little bit contrary to many of the developments that are going on in biomedical research, where there is a great interest in use and reuse and repurposing of data for different types of research and future research. And so this is a tension that is now a problem. I'm going to skip the rest. In practice, I am sitting on this research ethics review committee, and I see those patient information forms that are terrible. And I'm feeling guilty that I'm actually part of the system that is requiring researchers to produce such documents, because they're so difficult to read and difficult to understand. And this is something that we found in our review too. For parents, when they are confronted with an informed consent procedure, it is even hard for them to tell the difference between clinical care and research, and that is a big problem. And I'm happy that Ramona has some good solutions for addressing this. But I talked about the burdens maybe in the beginning, but there are also benefits, because when kids are included in research, they often are fed back maybe the results of their genetic tests. Maybe this is one way of accessing genetic testing services that would otherwise not be provided in standard clinical care, for instance. And so that is something that I'm hoping that we can maybe talk about later also. What is the value of genetic testing? What are the benefits of genetic testing? What's the value of knowing that a genetic variant has caused a problem? But there's also, of course, risks involved. This is still the framework that we were talking about.
That's just an Irish wedding.
Thank you. That's good to know that. So I think this is a good quote that illustrates that, of course, when we're talking about ethical issues, we're often talking about burdens and risks. But here too, any risk assessment must also include the risk of not having data. So yeah, that sort of illustrates that point. Let me see, because I don't want to take too long. There is data protection and privacy issues, but I want to skip to a next point, actually, namely the point of incidental findings. I think that this is an interesting discussion that is currently going on. You can see incidental findings are the things that you've not been looking for. And you can see that maybe as a risk or as a benefit, actually. There in the Netherlands, incidental findings are usually still considered a risk. And I think that is interesting. A few years ago, the Health Council of the Netherlands produced a report on incidental findings. This is in the context of clinical care. So when a patient comes in for a diagnostic test, the report says that being a good doctor, we have a noun for that in Dutch, goed hulpverlenerschap. Being a good doctor means that if you offer a diagnostic test to a patient and you have a choice between similarly valuable testing options, you should always pick the testing option that has the most limited potential to lead to incidental findings. So you should always test as targeted as possible. This is also in line with the European Society of Human Genetics guidelines on offering testing. And the general idea is to avoid incidental findings, because a patient is coming to see you with a question and you can offer them a test that answers the question, then all the other things shouldn't be detected. So if you can avoid the detection of incidental findings, you should. And this is a very sort of clear stance that is a little bit in contrast with some of the practices that are going on. For instance, I know of one medical center in the Netherlands that when it offers whole exome sequencing to patients, it also, as sort of a service, says, if you want, you can also, I can sort of tick the box and you can get pharmacogenomic screening. And then you get sort of a pharmacogenomic passport that informs you about all sorts of individualized sort of risks when it comes to prescription medicines. And especially pharmacogenomic markers are especially relevant also to psychiatric diseases, because we know from very many psychiatric medications that people metabolize those compounds differently. And so this is sort of a service that is offered in this medical center is actually against what the Dutch Health Council has suggested. And also in the Netherlands, we have this Population Screening Act that would also actually restrict these types of offerings in clinical care. It could even be that this university medical center is doing something that they could be punished for, like legally, because they're actually offering something that they shouldn't, not without the license, and they don't have a license to offer this pharmacogenomic screening. So this is the situation in the Netherlands. In America, I don't know if you're aware of this, but a couple of years ago, the American College of Medical Geneticists said, if anybody comes in for diagnostic, next generation sequencing type testing, you should answer the question, but you should also look at this set of about 60 genes that are associated with a whole range of other genetic conditions that are treatable, and some of them that are also sort of late onset. So this could be that somebody comes in for, let's say, maybe intellectual disability or something like that, and is offered whole exome sequencing, and we're also actively looking for other things like Lynch syndrome or other hereditary cancer syndromes. And there was a lot of criticism when this college produced these guidelines, for instance, because they've also suggested that patients would not be allowed to opt out of getting all these extras included in their testing. But this is something that runs counter to what we in the Netherlands have been proposing. And so this is a question that still needs to be answered, I think, over the next couple of years. What should be the direction that we're going to? Is it that a patient comes to see the doctor and is offered a targeted tests? Or are we moving into this direction of, you know, when we're doing sequencing, we can derive so much information from the genome. Maybe we should try and interpret as much as possible and give you back as much relevant information as possible. We don't know how this will play out. Another thing that I wanted to talk about was another discussion that is now going on, and this is in relation to one case of a family in the Netherlands. I accidentally or incidentally know these people because I studied with somebody who was a person in this family. And I met the father, Aad Klaassen, and I've spoken with him a couple of times. And his story has led to a huge discussion in the Netherlands and also to revisions of guidelines for counseling and family communication. And I think it's an interesting example of something that we also just briefly touched upon in Dr. Bradley's talk about the right to know and about maybe the effectiveness of family communication. This Aad Klaassen, his daughter had, when she was very young, had cancer that had already metastasized. She had 2 small children. And of course, he was very concerned about his daughter, and he started to talk to friends and family members about what was happening to his daughter. And he talked to a cousin, and the cousin said, oh, maybe 10 years or 20 years ago or something, your aunt, my mother, saw the clinical genetics department in Rotterdam also for breast cancer. Maybe that has something to do with it. And so Ad Glaase called the genetics department at my hospital, asking them, look, can you find in your files anything about my family members and my aunt? And the person on the phone said, oh yes, what's your name? And tell me about this. And the person on the phone said, I can even see you. What's your date of birth? And his date of birth was actually in the computer. And he was part of a family tree. But what had happened is that a mutation for hereditary breast cancer, a BRCA mutation, was found in the aunt. And the daughters were informed, so his cousins more or less, and maybe they had options maybe to prevent that disease from happening in those daughters. But somewhere along the line, things had gone a little bit wrong. So the aunt and Ad's mother may have spoken about this, but Ad had only 3 brothers. So the woman, the grandmother, who had already died, had only 4 sons. We think that maybe something has gone wrong there. Maybe the 2 sisters thought, oh, this is not relevant for you, you have only sons. But the mutation was passed on to Ad, and then he passed the mutation on to his daughter. And also here, this is an example, he felt, of course, terrible guilt. But he was also angry because he had been on the phone with the genetics department, and the genetics department had actually said, we do have your information here. And he was thinking, why has it not reached me, right? And so he became a little bit of an activist. He also said, it's okay if you tell the story to people, because he finds it very important. And he started a complaints procedure with the hospital, and the hospital said, yeah, this is of course very tragic, but nothing's gone wrong. Nothing in terms of liability has gone wrong. This is just how we do it. We don't actively let people know that they're in a database. This is something that goes through families, right? And so there's this major discussion going on. In the Netherlands, should this be changed? I'm in a working group, ethics and legal working group of the National Association of Clinical Geneticists. They are working on a revision of the guideline for family communication, but the process is taking very long. People find it hard to agree on how things should be done in the future. This is what the existing guideline says. I translated this from Dutch. The basic principle is that it belongs to the responsibility of the clinical geneticist to see to it that optimal information provision is offered to family members in case of hereditary and familial cancer. The new guideline, the revision, will cover any genetic condition. This was in the past only done for cancer, because this was sort of a paradigmatic case where you could have healthy family members, and this is a disease that is arguably treatable or preventable. But now we're trying to translate this to other genetic conditions too. So what we do in practice is the index patient is supported in the sense of trying to identify who are relevant relatives to talk to about this genetic risk. And they receive a family letter. We heard it being mentioned already. So some text that you could use to inform other people in your family. And then some counselors and some do and some don't, may get on the phone after a couple of months to ask, how is the family communication going? Are you experiencing any troubles? Can I help in some ways? To sort of check whether this happens. But this is not something that is required. This is not something that is being done actively by all counselors. And in this system, less than 50% of family members, it depends a little bit on the condition, sometimes even maybe only 10 or 20% of family members are being reached. So there is now this discussion, should clinical geneticists be more active? Actually, in practice, the discussion goes a little bit into the other direction, like, oh, maybe we should be careful not to include personal data in these family trees. Not a date of birth, not names, just, there's one cousin between the ages of 20 and 30 that has had the disease. And but now, so this discussion is currently going on. These are some thoughts for discussion that I had proposed. I went through the research ethics part, I went a little bit quickly, because I thought maybe it's not that interesting, but I do think that we are moving into this direction of trying to use clinical data for research purposes in very many countries in this time. And there are concerns about this merging, this blurring of boundaries between clinical care and research. From the focus group earlier, I learned that in many countries there's a great willingness among patients to share data. I think we see that in very many countries. That is good. Should there also be ways to opt out of taking part in this big research effort? Should patients also be able to continue to receive care without having to take part in research? I think that's a relevant question, as even in the Netherlands, some hospitals, university hospitals, are working towards getting consent for research. When patients enter the hospital will say, you have now entered an academic hospital, we will be using all your information for all sorts of research purposes, and there's no way really to say, or there is a way to say no to that, but it's going to be difficult. Should physicians be more active maybe somehow? In the Netherlands, the guidelines say that in some cases, especially when serious harm can maybe be avoided, clinical geneticists should be able to approach family members directly, even though the patient maybe doesn't want this, and so overrule their preferences. But that's only in extreme cases where there's serious harm to be avoided. These are also questions having to do with this right to not to know that we've sort of traditionally supported over the decades, that especially when it comes to predictive information and things that may happen in the future, that patients should also have a right not to know. But if these things are happening, this maybe greater tendency to share incidental findings, this greater tendency to be more active in making people aware of their risks, what happens to that right not to know? And there's issues around recontact too. I liked it that this morning Dr. Bradley was talking about that the responsibility to reestablish contact was given to the patient, and explicitly not by the health professional. In the Netherlands, we talk about a shared responsibility for recontacting in the future. And I'm a little bit worried about how that will play out, because when a responsibility is shared, who's going to then take the responsibility? So I'm also interested in how there are maybe different views about how to rearrange that. So these were my discussion points. I have a small list of other issues. But I don't know what we can do now, because we had planned
We're
a
going
focus
to have
group.
a focus group now.
Okay.
Yeah, over coffee. I think we had a break for coffee and then the focus group, but I think we have to combine the two in the interest of time. And we've about a half an hour. So, I mean, unless anybody has any burning issues for Eline about some of the ethical issues that she's raised, I think we should just grab a coffee and break into the focus groups. And like this morning's group, I think we're going to have some general discussion, and then there are a few kind of specific examples we ask the facilitators to try to work through, if that helps.
And we'll focus more on the psychological impact and social implications.
And stigma.
Yes,
Yeah.
and stigma.